We are live on YouTube. We are live on. All right.
David, are you hosting?
Yes, sir. Yes, Dr. Schwartz.
Awesome.
Nice to
Hold on, I
meet
gotta take a phone call.
The webinar has started. We're gonna give a few minutes for more people to get here, and we'll do the introduction.
All right, Iggy, thank you very much. My name is David Altschuler. I'm Dr. Morcos's fellow here at the University of Miami in Cerebrovascular and skull-based neurosurgery. And it's my honor to do Dr. Morcos's usual short introduction here. He is in Strasbourg, France, teaching a skull-based anatomy course. So we have three phenomenal speakers today, Dr. Sargi, Dr. Schwartz, and Dr. Cavallo. And Dr. Morcos did pre-record a short introductory video for us all this evening. So I'll ask Iggy to play that for us now.
Stand by, going. Sharing the screen right now. Please stand by. I have a difficulty here. 1 second, please. One second, please.
Ignacio, I have the video too, if you'd like me to share it.
No, I have it right here. Thank you so much.
Good evening, everybody. I am sorry, this is a pre-recorded introduction because I am in Strasbourg, France, at a course, and we realized the Wi-Fi is not completely reliable. So I welcome you again to the monthly Cerebrovascular and Skull-Based Surgery, University of Miami Symposium. This is now session 44 on June 16, 2022. It's a great session today on management of cellular and supracellular lesions. We will introduce a panelist in a couple of seconds. Of course, the directors and co-directors of the course, you can see them there. It's Carolina Benjamin, Mike Ivan, Bobby Stark, and our two panelists of today, our PG3, Eva Wu, and David Altschuler, the Cerebrovascular and Skull-Based Fellow. Here is David, who is finishing his fellowship with us here, and he's going back to University of Michigan to join his program where he did his residency. It's been a tremendous pleasure to have him this year. And of course, Eva, who is transitioning to PG4 next year, will also be a guest discussant. Many thanks to the team that makes these webinars possible, and of course, all of you who attend them. We have also an announcement of the future sessions. We have 4 sessions coming up. Please mark your calendars, maybe take a screenshot of those dates. You will see the flyers in a minute. July 21, August 11, September 15, and August 13. Please notice that August 11 and October 13 are not the third Thursday of the month like we try to do because of conflicts with other important meetings. So beware of the actual dates. It's not always the third Thursday of the month. Next month, July 21, will be surgery for brainstem cavernomas with Mike Lawton, Peter Vashkozy, Oliver Bozinov. August 11 will be petroclival meningiomas, debate on approaches, Eduardo Vellutini, Siviero Agazi, and Jim Liu. September 15 will be treatment controversies in AVMs, Amir Dedashti, Gary Steinberg, and Adam Arthur. And October 13 will be surgical management of acoustic neuromas, Ashok Astagiri, Martin Shamez, and Mustafa Bashkaya. And of course, I'll announce later the remaining month what we have installed. As you know, we always have spectacular speakers who participate. But coming back to tonight, and again, my great pleasure to introduce our 3 wonderful speakers in the order in which they will speak. Luigi Cavallo, who's professor of neurosurgery at Federico II University Hospital in Naples, Italy. Luigi will talk on endonasal approach to unconventional pituitary adenomas. Of course, he and Professor Capabianca, his senior partner, have been instrumental in pioneering endonasal endoscopic surgery. Next is Ted Schwartz. Ted is professor of neurosurgery, director for Center for Epilepsy and Pituitary Surgery. He is a professor of minimally invasive skull-based surgery at Weill Cornell Brains and Spine Center in New York. Ted, of course, is a pioneer as well of skull-based surgery and is going to talk to us about the craniopharyngioma conundrum. We've asked him to talk about the difference, if any, between gross total resection versus subtotal resection with adjuvant radiation therapy. So that would be also a very exciting talk. Last but not least is my partner in and colleague from otolaryngology here at the University of Miami, Zuka Sargi, who is currently the treasurer of the North American Skull-Based Surgery. Zuka, who is a spectacular surgeon, professor of otolaryngology and neurosurgery, will talk about skull-based reconstruction, principles, pitfalls, and pearls. Zuka, we could not really have a complete skull-based program here at the University of Miami without Zuka's contribution in every aspect of it, in research, in clinical aspects of the program, and in dealing with the most complex of the skull base tumors that we handle as a team. So again, I thank those three speakers, and I'm sorry I cannot be there in person because of the Wi-Fi issue to participate in the discussions, but I'm sure everybody will keep it interesting. So without further ado, I invite Luigi to share his screen and start his presentation, assuming he is able to also make the presentation because he is long distance if he has not pre-recorded his presentation. Thank you.
Hello to everybody. Thanks again for the invitation. It's really a pleasure for me to participate to this symposium. My topic today concerns the so-called unconventional pituitary adenomas. So before speaking of the unconventional, we have to know what are the conventional pituitary tumors. And these are the typical conventional pituitary tumors. These are the daily case. I mean, small intracellular, intraglandular pituitary adenoma, but even intrasupracellular pituitary tumor with regular shape, regular pattern of growth of this tumor. Sometimes they grow downward inside the sphenoid sinus, which makes the tumor removal easier. No tumor extension in the subarachnoid space, no irregular shape, and so quite easy tumors to be removed. So for this kind of tumor, what we have to do is just a straightforward approach without any need of middle turbinectomy, which has to be just lateralized. Of course, we have to do wide sphenoidotomy to move properly the instrument, and we need, of course, to Nostril Approach. This is the type of cellular opening we have to perform from one carotid to the other, to the clival recess to the tuberculum cell. When we have to remove this kind of tumor, we have to remove sequentially, starting from the bottom, then extending laterally tumor removal toward the cavernous sinus, and only at the latter stage we have to remove the supracellular part. This because to avoid an early prolapse of the supracellular component of the tumor inside the cell. And this is the typical intrasupracellular pituitary tumor, which can be even quite large, but always growing below the supracellular cistern. You see that this cistern become a sort of barrier which protect ourselves during the tumor removal. You see that the supracellular cistern prolapse at the end of tumor removal, so that even in a large tumor like this one, you can be able also to preserve some residual pituitary function. This is another case. You see regular shape. This is another one with anterior and a little bit lateral extension, but you always work below the diaphragm. But the unconventional pituitary tumor are quite different. As you can see, the shapes start to become more irregular, not necessarily large or huge tumor, but with irregular shape, sometimes with infiltration of the subarachnoid space and extension inside the ventricle sometimes, or even into the retrocellular space, another extension inside the ventricle. So these are the type of a tumor in which we have to be very careful. This is the key point of this tumor. You see double-shaped pericellular extension, violation of the subarachnoid space, and sometimes involvement of neurovascular extraction. For this kind of tumor, during the last 15 years has been proposed this extended approach, which some way have been used even during the microsurgical transcranial approach by some pioneers. And what we have to do practically is it's a sort of a craniectomy just in front of the chiasm using this transplanum supracellular approach. These are the limit of bone removal. As you can see, our bone opening is not limited just to the cell, but we have to extend our bone removal also over the posterior part of the planum sphenoidale. What we can do with this approach, we can do an extracapsular dissection. You see in this video, what we can do is to work either inside the tumor capsule, but we can also dissect the tumor capsule from the neurovascular structure. And these offer some benefit, especially when we have to free the tumor capsule from the stalk, from the chiasm, or from the vessel, as we will see. So we can use this double corridor. This is transarachnoidal corridor, and then we have, of course, the transcellular approach. This was considered a sort of a contraindication in the past for transcranial root, sunglass-shaped non-functioning adenoma, and you see that using this extended approach we can remove this type of tumor. This is another case you see with the paracellular, supraparacellular extension. You see this component of the tumor. So what we can do is, of course, to start removing the cellular part of the tumor, and you see the consistency is quite soft, but at a certain point we have the prolapse of the supracellular system. So what we have to do is to open the system, because we still have a large part of the tumor which is still inside, so we have to extend our dural bone opening over the planum, and you see here that we are resecting the larger supracellular part of the tumor, which was impossible to fall down during with a regular transcranial approach. You see, we have to dissect the tumor from the brain and from the neurovascular structure, but you see at the end that that was the tumor dome, just laterally to A1, A2 complex, the shape of the residual cavity after tumor removal, which is of course quite nice. And this is an early MRI with the suppression fat sequences. You see almost not touching the brain. This is another case, even more complex. You see with this irregular shape of the tumor. You see these are kind of tumor that in the past we were using to remove with the transcranial approach. As usual, we start with the bulking of the cellular component of the tumor, and you can notice that we don't have any descent of the supracellular system. The tumor is quite elastic, not so soft. So what we have to do again is to open the diaphragm to dissect the capsule of the tumor from the optic nerve. Pituitary tumor are more bleeding than craniopharyngioma, and sometimes even then more meningioma. So we have to try to resect as much as possible this tumor until we see the normal tissue. We cannot leave any piece of capsule or tumor around the vessel, because otherwise we have the risk to have a vasospasm after the surgical procedure. Here we can recognize the stalk with the residual gland. This is A1 with the chiasm. At the end we pack the residual cavity with the fat, and we cover with Nasoceptal Flap with the 3F technique I will show you later. That's the post-op MRI. You see the piece of fat, how much is resorbed after 3 months. This is another case. You see with some extension of the tumor even inside the ventricle. And again, we start with the transcellular approach. Then we have to move outside the capsule in order to dissect the capsule from the neurovascular structure. You see the optic nerve. This is A2 on one side, the ACOM, the other A2 here. Not very easy to recognize the structure, and this is the piece of tumor growing inside the third ventricle through the lamina terminalis. Very strange way to grow. This is a blood clot. This is the ventricular cavity free of tumor, and then at the end the view of the surgical cavity after tumor removal. This is the diaphragma cell coagulated, and post-op MRI with good tumor removal. Another case with tumor growing inside the third ventricle. Of course, like a craniopharyngioma, we know that today we can enter this cavity through the nose, just following the tumor through this corridor. I'll skip the video just to show you that we can really enter and remove completely this tumor inside the third ventricle. Sometimes we have to combine the approach because the nasal root is not enough, and I'll show you in this recurrent tumor we really have to face with the scars, with the tumor entering even inside the third ventricle. We try to resect as much as possible from below, but then we have to go from above, and the supraorbital approach is nice to be combined. You see the opening we made from below, you see the optic nerve, you see some scars. We have to free the nerves, we have to open as much as possible the cysts which were growing around the optic nerve and above, and but at the end we were able to free the optic nerve and to resect the vast majority of this tumor. You see again, this went from above, and the reconstruction coming from above, and then the post-op MRI with quite good tumor removal. This is from our series of pituitary tumor. You see that the extended approach has been used for pituitary adenomas just for 5% of the cases. This means that the vast majority of pituitary tumor can be removed through a standard approach. There's no need of extended approach. But these 5% maybe were the tumor that in the past we were treating with the transcranial route, and that today we can manage with the extended approach. You see the vast majority are non-functioning tumor in this series. Of course, the complication rate is higher if we compare to the standard transsphenoidal route, but it's mainly morbidity, no permanent morbidity, and in most of the cases the troubles can be solved. This is just one of the most feared complications we have to deal. Look, this case not so big, but it was a recurrent case. Recurrent pituitary tumor, not always easy to manage. You see, we used the extended approach. We removed as much as possible this tumor, but we left some piece of capsule. You see, we left some piece of capsule, and and as a result, this patient, few days after surgery, had some deterioration in clinical activity, and you have to think about vasospasm when it happens, and you have to be ready to treat as soon as possible, because if you treat properly this patient, you can solve the problem without any permanent defect. Other words about reconstruction. This is the technique we are using now, the 3F, quite easy to be performed, made just by fat, flap, and flash mobilization of the patient. And you see in this series that if we compare the pre-3F era with the 3F era, the rate of post-op CSF leak has reduced considerably if we compare with the past. Just a few considerations about the instruments, because when you use this extended approach for pituitary tumor, you absolutely need proper instruments, and especially longer one, and especially if you have to reach the third ventricular cavity, you need the 15 centimeter in length instruments. So I think this is my last slide. I thank you for your attention. As you can see, this presentation has been recorded from the airport. I really enjoyed, and really hope to see you in present in the near future. Thank you again.
Well, thanks to Dr. Cavallo for that recorded lecture. Fantastic presentation. Next up, we have Dr. Schwartz from Cornell, who needs no introduction himself, a legend in endonasal surgery and minimally invasive skull-based surgery.
David, thanks so much for having me. I'm going to share my screen and then get started. Let me know if it doesn't look right to you, but hopefully it will.
Yep, looks good, Dr. Schwartz.
I'm in presentation mode. So I'm going to talk to you guys about craniofrangiomas. I have about a 20-minute talk, which should cover my time. I have some disclosures, nothing that exciting, a bunch of fellows and residents who helped me put a lot of this data together, so I'm really grateful to them. I work out of Cornell, which is part of New York Presbyterian Hospital in Manhattan, and we started this institute, myself and Dr. Anand, and it's expanded since then. This is what our OR looks like for endonasal surgery. Just of note, we use a scope holder, which a lot of people don't do. So when you see the videos, just keep in mind it's on a scope holder, and obviously I don't feel it limits us in any way, and I don't need the ENT surgeon to hold the scope throughout the operation. I just move it around a lot. So craniofrangiomas are rare tumors. There are about 620 of them a year in the US. That includes adult and pediatric. And as we know, some of them are papillary and some of them are adamantinomatous, and I'll go through the differences between those two. And the papillary ones are rare in children, much more common in adult. Almost all the pediatric ones are adamantinomatous. Craniofrangiomas can grow in multiple directions, which is what makes them very challenging. They really can go almost anywhere, but they do start from the stalk, and so they become a paracellular pathology. There are different peaks in the presentation. There's a pediatric peak and then more of an adult peak. And I work very closely with the pediatric neurosurgeons at Cornell when we do our pediatric craniofrangiomas, and there's specific things you need to do that are unique to the pediatric population. So I'm going to talk a little bit about the molecular biology, medical treatment. Jacques wanted me to talk about gross total resection versus subtotal radiation, peds versus adult, whether to sacrifice the stalk or save the stalk, and then a little bit on craniotomy versus endonasal. So the biggest thing in the last couple of years after endoscopy was this whole concept of the mutations that we see in the craniofrangiomas. And what was found was that most of the adamantinomatous have this beta-catenin mutation, and the papillaries have a BRAF mutation. And what made that particularly exciting was that there was a chance of treating the papillary ones with chemotherapy. Now, it turns out you can make the diagnosis of papillary versus adamantinomatous almost purely on imaging and age. And if these are papers that looked at that, if you have a supracellular tumor, spherical, solid, homogeneously enhancing in an adult, it's almost guaranteed to be a papillary craniophrangioma. And they tend not to calcify. Whereas the adamantinomatous are calcified, they're more in pediatrics, they're cystic, they can be cellular and cellular supracellular. And what makes that exciting is that you can potentially identify these tumors preoperatively, and if they are papillary, treat them medically with MEK inhibitors and BRAF inhibitors. And it has, a couple of papers now have shown great responses just to chemotherapy, although you have to keep the chemotherapy going. When you stop the chemotherapy, the tumor often grows back. And so it's great to do in preparation, for example, for radiation therapy, or maybe to make a tumor more resectable. Endocrinopathy is a key component of craniophrangiomas, both pre-op and post-op. And it's really important when you talk to your patients to let them know that there's a very good chance that they're going to be hypopituitary, regardless of what treatment they have, whether they have surgery or whether they have with subtotal resection, whether they have radiation or not, or nothing, that often the pituitary axis will be compromised. You really have to work closely with your neuroendocrinologist to manage these well. The other thing is this question of hypothalamic involvement with the pediatric patients, which I think is not a completely resolved question, but originally Christian St. Rose wrote a lot about hypothalamic involvement, and those that were invaded, particularly in the pediatric patients, he felt it should not be resected. And I'll touch on that a little bit. When I trained, the question was, does gross total resection make a difference compared to subtotal resection with radiation? And a lot of the data showed that it didn't, that maybe a subtotal resection with radiation was just as good as a gross total resection. But all of the data that's contributed to this controversy was before endonasal endoscopy existed. So I would argue that we sort of have to revisit this question in the age of endoscopy. And there are a lot of different treatment options that are out there because these tumors can be so difficult to treat, and you have to think about Ommaya drainage and cisfenestration, fractionated radiation, intracystic bleomycin, interferon alpha, and all those things have been tried for this tumor. But surgery, in my opinion, in general, is first-line therapy. The goals are to make a diagnosis first and foremost, adamantinomatous versus papillary. You want to decompress the chiasm if vision is lost, and then you potentially can cure these. If you take the whole tumor out, the patients are cured. A lot of the chat groups, the patients will say there's no such thing as a cure, but I think it's maybe the people on the chat groups that haven't been cured that are being told that. But I have, patients who are, 10, 15, 20 years out from cure with no recurrence of their tumor. So if you can cure a patient, that's a wonderful thing to do, but obviously you want to maintain quality of life. We looked at some of our patients where when the story originally came out about papillary versus adamantinomatous, we found 16 patients who were papillary, tried to figure out what was specific about them, and none of them had calcifications, and we got gross total resection in 78.6%, and some of them had transcranial surgery, none of them were gross total resections, but I'll get back to that question of best approach, but no CSF leaks. But this was very early when we were first kind of discovering these and trying to figure out the differences between the two tumors. So for pediatric patients, it's more acceptable to offer a subtotal resection to avoid hypothalamic damage. And that's important to keep in mind. A lot of these patients, if you damage the hypothalamus in a child, they will become morbidly obese, they'll have cognitive changes, and you really have to be super careful. But it doesn't mean you can't be aggressive. It doesn't mean you can't try to cure these children. And I'm going to show you a great case that has changed my mind a little bit about that coming up. With respect to craniotomy versus endonasal, craniotomy was always the mainstay. It's got a wide exposure, better lateral view, but there's a lot of brain retraction, risk of seizures is high, wound infection, optic nerve manipulation. The endonasal has a better midline view, less optic nerve manipulation, no brain retraction. And of course, there's the risk of CSF leak and a limited lateral view. The approach is similar to what we saw from Cavallo, except that we take off a little more of the tuberculum sella in all these cases. Now, I do a very small opening for my craniophrangiomas. It's remarkably small. It's literally the size of a nickel. It's even smaller than this. I take off the top of the sella, the tuberculum, and just a little bit of the planum. And the reason is that you're working below the optic nerve in the majority of cases. And if you're working below the optic nerve, it doesn't make sense to open up bone that far above the optic nerve. And I'll show you what that looks like. The hypophyseal arteries, superficial hypophyseal arteries are very tricky in these operations because they often are spreading right across the entranceway to the tumor. And I do my best to try to dissect those off. They are redundant to some degree. And what's very tricky about this surgery is there are some hypophyseal arteries that you can take, and there's some that you can't. And I've had instances where I've taken small ones where I had no choice and the patient's vision was perfect. And I've had other instances where you take one and they lose vision in an eye. And it's impossible to know, or very difficult to know, what that's going to do when you take one of those small arteries. So we try to save all of them as best we can. And obviously, if you have to take one to get the tumor out, we do it and hope that it is redundant and that there's anastomoses that fill in for that. But you have to be super careful about that because we really haven't defined which of those you can take and which you can't. So the traditional approach, we see Netter's diagram here. You can see the brain being retracted out of the way and the optic nerves in the way. This is a book from Spetzler showing craniofrangioma. You can see that the approach from above basically shows you the normal anatomy. You can barely see the pathologic anatomy, and you got to work in between all these little corridors to get it out. But when we use an endoscope from below, you get a beautiful view of all of this anatomy. You can't beat that view. You can see below and above the optic nerve and everything you need to see to take out these midline craniofrangiomas. So here's an example of a solid midline craniofrangioma. It's fairly big. The sphenoid sinus is not fully aerated. It's above a normal size sella. You think, well, maybe I should do a craniotomy here. Maybe I should do an eyelid. But the truth is, endonasal is perfect for this. When you ask the question, where's the chiasm is always right below ACOM. So if this is the ACOM, the chiasm is going to be up here, which means you got plenty of room to get this tumor out. So here we have to enlarge the cell a little bit. We'll open up the dura. We give intrathecal fluorescein in a lot of these cases. It's a big solid tumor, so you have to internally decompress it first. But once you've internally decompressed the tumor of the solid component, you can then fold it in on itself and start to do your sharp dissection around the outside. And here we're using sharp scissors to dissect. You can see the PCOM poked into view. Here's the back of the chiasm. You can see that beautifully and dissect it off. Here's the stalk. We're dissecting the tumor off the stalk. I try to save the stalk as long as possible, and if I can save the stalk, great. And if I can't, I sacrifice the stalk. And then you can take the tumor off the walls of the third ventricle. Here's the PCOM and PCA looking lateral. We have a gross total resection of the tumor, which you can see on the post-op scan. And you see the stalk has been preserved here. Now, it doesn't mean the stalk's going to work, and I'll talk about that, but I do try to preserve it if I can, but I want to ensure I get a gross total resection of the tumor. Otherwise, I generally sacrifice the stalk. Here, we've done a flap and a gasket seal. I've gone through a bunch of different closures, and I'll talk to you where I am now, because I have something that I've changed to. The beauty of the endonasal approach is there's no retraction of the brain, and there's no flare signal in the brain because of retraction. Now, how bad can that flare signal be? Well, this is a patient who was operated on in my institution, had a craniotomy. You can see the temporal lobe flare signal, 2 operations, radiation, the tumor still recurred. And where did it recur? In the medial optic canal that they couldn't see through the craniotomy. Look at all the flare signal change from retraction of the brain. Here's the tumor that's recurred. They were finally referred to me to resect it. I opened up the medial optic canal from below. I'll sharply open up the optic canal, and then you'll see I'll roll the tumor out from the inside out. Here I'm opening up the optic sheath. We'll find the edge of the tumor and peel it off the optic nerve. It's already fairly gray because it's been radiated. But you see what a beautiful view of the medial optic canal you get. And then obviously when it's stuck to the nerve, you got to sharply dissect it off the nerve and create a plane for yourself so you don't damage that nerve. You can see the green intrathecal fluorescein, which we use only if we put in a lumbar drain do we use it. If not, we don't give it. And here we got out the rest of the tumor. You can just see the sharp dissection getting it off the nerve, how careful you have to be. But what a perfect, beautiful view of the bottom of the nerve. You don't have to manipulate the nerve at all to get this tumor out that it was extending up into the medial optic canal. And this is post-op. You see the nerve is reached.
Did he freeze? Did we lose Schwartz?
Seems like it.
Let's give him a minute to see if he comes back.
All right.
Yep, we lost him.
We lost him. I'm sure.
Back.
Oh, there he's reconnecting.
I'll edit it back. Like nothing happened.
Dr. Schwartz, you're
David?
muted. There you go.
Yeah, so you won't believe this. My computer literally just shut down on its own, which it does intermittently. And I've had IT come by and look at it and they can't find a problem. And it literally just shut down spontaneously in the middle of my talk, which is just insane.
Well,
So
the
you give me-
videos and the pictures are beautiful. Do you want us to skip ahead to Dr. Sargi while you get back
Yeah.
online, or?
Well, I can be back on in like 20 seconds. If you can wait.
Okay, perfect. We will
My
definitely
computer is
wait.
restarting now. I apologize to everybody out there. But I'm sure you can relate. in
And
a
keeping
sad-
us in suspense, those great surgeries, great videos.
Yeah, I got more. Sorry about that. All right, I'm logging on now. Everything is reopened. It only, by the way, the good news is it only does this once. So once it restarts, I'm good to go. I have no idea why it does this. If anyone has any suggestions.
No, I'm just glad to hear it's universal. I've experienced it at Michigan, here in Miami, and it seems like it happens in New York too. So glad it's not just me.
It looks
Okay,
like it's
so-
an update. Something
I'm
with an
gonna-
app.
What's that?
It looks like it's updating, so that's why it shuts down. It's automatic update.
Could be some automatic updates, usually late in the afternoon. Okay, I'm joining on my computer. So I'm going to log off here. Okay, I'm back. Sharing my screen. That was insane. Let me go to the slide that I want to get to. Sorry, everybody. Here we go. So I was going to show you this beautiful picture. So this is just another example of a craniopharyngioma, just showing how big they can be and still be removed endonasally. Oh wait, Teams, things are still restarting on my computer. So can you see that Microsoft Teams thing or no?
No,
Okay, fine. It's just on my computer.
it looks like you're sharing something else, though, because we do see something.
Can you see the post-op scan? David, does everything look okay?
Yes,
Yes, we
it
can
looks
see
good.
Okay, fine. So I'll keep going. All right. So here's the post-op. So we wrote a paper about this question of, which cranios might we not be able to take out? And one question is, well, if the optic chiasm is very low and you're working between the gland and the chiasm, maybe you won't be able to take it out. So we looked at our cases and asked the question, how big is that space between the pituitary gland and the chiasm, which we call the CPC, like chiasm pituitary corridor? The average was 10 millimeters. The range was 5 millimeters to 20 millimeters, and the number had no relationship with our ability to achieve a gross total resection. So even if the chiasm is pretty low, you can open up a little more bone, elevate the chiasm, and work underneath it to get into the ventricle. So another little tidbit there. How effective is endonasal compared to craniotomy? Well, a couple of years ago, we looked at the literature, and this is a retrospective review of the literature. But if you compare gross total resection rates of transcranial versus endonasal, and you look at before 2012, so it's early endonasal, gross total resection rates were not as good with endonasal. CFF leaks were too high. Visual improvement was about the same. If you look from 2012 to 2017, and now this is already 4 years ago, gross total resection rates jumped up till they were as high as craniotomy. CSF leak rates at some places were lower, down to 3%. And visual improvement rates were definitely higher. So this was good evidence that the endonasal approach could get out all the tumors. CSF leak rates could be as low, but the visual improvement was definitely better coming in from below. We then looked at our institution and we took 106 craniofrangiomas resected over like a 15-year period. And we took all the cases and we sent them to 4 experts blinded. And we said, only choose the cases that could be done endonasally or through a craniotomy, equally with either approach. And we had 26 cases that could be done either way. And of those, 21 were done EVA, 5 TCA. And so we compared the results. And what we found was the gross total resection rate was much higher when it was done endonasally. The change in flare in the brain, much higher if you did a craniotomy. Need for radiation, much higher if you did a craniotomy. Recurrence rate, higher if you did a craniotomy. Visual outcome, much better with endonasal. Transcranial, nobody got better. And then for post-op complications, a lot of cognitive deficits with the craniotomies. And of course, there was 1 CSF leak in the endonasal and none with the craniotomy, so a little bit better there. But overall results were dramatically better when we took these out endonasally. We've done about 135 patients. This slide's a little old. We've probably done more, so we've done quite a few cases. Gross total resection rates, we get about 86% of the time. We can get out more than 95% of the tumor, 95% of the time. Visual improvement gets better about 80% of the time. We have about a 3% CSF leak rate. But I have a way to get that down even lower, which I'll talk about. So we originally wrote about a gasket seal, which was an onlay of a soft closure. We would wedge in a piece of bone, cover it with a vascularized flap. And that worked very well for our 3% leak. I'm moving to the point where I don't want to take any fasciolata anymore. I don't want to take any grafts. I don't even want to take fat anymore. And I'll show you how I'm getting away from fat. But when we started using acellular dermal matrix instead of fasciolata, our results were great. So we realized we didn't need to use fasciolata, so we stopped doing that. And then I started using hydroxyapatite as my closure. And I thought that I had discovered it, but then I looked back and Dusick Kong's been doing this for like 10 years and he wrote 3 papers on it. I didn't realize that. So I give him full credit, but I'll show you what we do now. And this is a meningioma case. Let me just make sure it's playing. No, it didn't play. Media not found. That's a bummer. Well, I'm going to save that for another talk. How we use Hydrocet to get no CSF leaks. Or if you want at the end during discussion, I'll find the video and show it to you because I'm not going to wait now. But Dusick did this study and it really works beautifully. So what I do now is basically I'll do a gasket and I'll cover it with Hydrocet and then cover that with a vascularized flap. No lumbar drain, no fat. So it's basically what I consider a perfect surgery, which is you take the whole thing out and you make no incisions except going through the nostril. You don't get fat, you don't get fasciolata, you don't put a lumbar drain in. The hydroxyapatite does it for you. And Dusick showed this actually in a couple of studies, and I've bought into it. I don't use it for pituitary tumors, just so you know. I only use it for meningiomas, craniofrangiomas, where I'm going into the third ventricle for extended approaches. Let's talk about the outcome. Is it worse for reoperations? Is it worth it to sacrifice the stalk to achieve a cure? How can we preserve pituitary function? If you don't, don't sacrifice the stalk, do you get a subtotal resection? And then what's the long-term recurrence rate? I'm going to talk about all these things. So first, reoperation. So we published this case paper a while ago, 35 first-time operations versus 22 reoperations. We published this probably 7-8 years ago. The gross total resection rate was the same, roughly 90% versus 80% for first-time operations versus reoperation. Visual improvement was about the same. The only difference was there were more anterior pituitary deficits with the first operation, and that's because a lot of the reoperations already had anterior deficits. And new DI was more common in reoperations compared with first-time operations. But again, we were being more aggressive, and so we were causing more DI. But the gross total resection rates were about the same. So what I like to do is if a patient has failed surgery, rather than go right to radiation, if I can get a gross total resection, I'll take him back for a reoperation. It's only if I can't get a gross total resection that I'll say, you know what, go to radiation because I can't cure them. We published this paper. We looked at 24 reoperations, and we had one group that had only had surgery and another group that had surgery plus radiation therapy. And what we found was that we were much more successful if the patient had not had radiation in the past. So the gross total resection rate was higher in group A, surgery alone, than group B. almost 90% versus 50% if they'd had radiation before. So if you've had radiation, it's very hard to get a gross total resection. So what I like to do is do my first operation, try to get a gross total resection. If I see a patient who's recurred and they haven't had radiation, I will offer them another surgery. I won't do radiation unless I can't get a gross total resection. What about the stalk? Should we sacrifice the stalk or should we leave the stalk behind? So here's the data on a bunch of patients where we did different things and I looked at the outcome. So for a gross total resection, if you sacrifice the stalk, you have 100% anterior pituitary insufficiency. That's not surprising. What is a little surprising is that I had one patient where I sacrificed the stalk who did not go into DI, but I tell all my patients that if I sacrifice your stalk, you probably will go into DI, but it's not a guarantee. But a gross total resection with stalk sacrifice, chance of recurrence, very low, need for radiation, very low. So if I get a gross total resection and I preserve the stalk to try to save pituitary function, how successful am I? Well, it turns out about a third of the time I can save anterior pituitary function, so that's good. And about half the time I can save posterior pituitary function. Now, if I preserve the stalk, though, does that mean there's going to be a higher recurrence rate? Because I haven't really taken out the whole tumor. The answer is a little bit, but not really. So the recurrence rate is still fairly low, and you can always radiate those patients, because again, you gave them the best shot you could. So you can preserve some pituitary function by saving the stalk, and you can have a durable cure even if you preserve the stalk. What's really important is the patients in whom I did a subtotal resection or a near total resection, in order to preserve pituitary function, was I able to preserve it? The answer is not really. Even those patients who had a subtotal resection or near total resection, they ended up having 80% had anterior pituitary insufficiency, 2/3 went into DI, and they all needed radiation therapy. And they all progressed a little bit till they got radiation therapy. So you're not doing them a huge favor by doing a subtotal resection to try to preserve pituitary function. They're going to lose it most of the time anyway. So if GTR can be achieved, offer reoperation before radiation therapy. If you can't get a GTR, often radiation therapy unless visual apparatus needs decompression, and then obviously you can go in and decompress. Let's talk about long-term control. How durable is the control? So I looked at a group of craniofrangiomas where I had more than 3 years of follow-up after endonasal surgery. 44 patients, mean follow-up of almost 6 years. I had a 70% gross total resection rate, and about 90% in whom it was the goal of surgery. Some of them I knew I wasn't going to get it in. Average tumor volume for those that had gross total resection was 4 cubic centimeters. For the subtotal, they had much bigger tumors, 18 cubic centimeters. So it's not exactly apples and apples. But what I found was if the tumor was less than 10 cubic centimeters, the chance of getting a gross total resection was very high, about 90%. And if it's greater than 10 cubic centimeters, the chance of getting a gross total resection was much lower. What was their long-term progression-free survival? Well, of those that had a gross total resection, no radiation therapy, we had 75% durable control. And for those who had a subtotal resection plus radiation therapy, a lot of those still recurred, even though they had a subtotal resection plus radiation therapy. So the data in my hands was not equivalent. The gross total resections actually did better. So other outcomes to look at for those that had gross total versus subtotal, lower rate of visual deterioration for the gross totals, but again, they had smaller tumors, higher rate of return to work in school. CSF leak rate was lower for the gross total resection, surprisingly, was 0%. Higher rate of DI for the gross total resections, which is not surprising. And I showed that data previously. Let me go back. This is what I want to show. So what about intraventricular meningiomas? Sorry, wait, no, sorry, these are pediatric cases. What about pediatrics? So this is 11 patients we had done less than 18 years old. Gross total resection rates are less in pediatric cases because, again, you're trying to avoid hypothalamic injuries, so you often leave tumor behind. Anterior pituitary function, 80%, DI, 63%, not surprising, pretty high. Only 2 patients had an increase of greater than 9% in their BMI, which is pretty good. Visual function stable or improved in 73%. All children returned to an academic environment. 10 in their grade appropriate for their age, 1 CSF leak, 1 loss of vision unilaterally from taking one of those hypophyseal arteries, and 1 abscess. So we do offer aggressive surgery to our pediatric patients as well. I want to show you this video of an 8-year-old girl who had a little bit of weight loss, actually. She had this very large craniophrangioma with hydrocephalus. And look at all the edema in our hypothalamus. Huge amount of edema in the hypothalamus. We thought, wow, this is going to be invading the hypothalamus. We probably were going to leave tumor behind. So we went in with the idea we're going to be aggressive, we're going to decompress, but if we have to leave tumor behind, we'll leave it behind. So let me show you what we found. Here we are decompressing the tumor. You can see we're working below the chiasm. We're trying to sweep those suprahypophyseal arteries up. You can see the PCAs below. Here we're taking out the bottom of the tumor. We're sweeping it off hypothalamus. We're using the NICO to decompress this. There's the hypothalamic plane. And we're saying, all right, if there's a plane, we're going to take it. Those are the mammillary bodies, sharply dissecting off the mammillary bodies. Look at this beautiful view up the long axis of the tumor. But we found a plane between the hypothalamus, and we just gently tried to sweep the tumor off the hypothalamus. It didn't look like it was going into it, although it was somewhat stuck. We were able to sweep it off the bottom of the fornices and then get out the whole tumor. So what's really interesting about this case, we're just exploring, showing you we got it all out. We did a gasket seal with, here we did Alloderm, Med-Pore, Nasoceptal Flap, and some green glue. Post-op tumor's gone, but look at all the flare. Here's the shocker. All the flare went away in the hypothalamus, gone. And that's like 5 days after surgery. So rather than making the edema in the hypothalamus worse, we actually made it better when we took out the tumor. So that got me thinking, and I look back at the Christian St. Rose data about hypothalamic involvement, and they're all of the data that Christian St. Rose gave us on pediatric patients was done with a craniotomy. There was no endonasal surgery. So in my opinion, the whole question of gross total resection versus subtotal resection and radiation, pediatric cases, all has to be revisited with endonasal surgery. What about intraventricular in the third ventricle? Well, people have said it's a contraindication endonasal, you can't do it, you do a craniotomy. We had 10 patients, we got a gross total resection in 9 out of 10. We got a 98% extended resection in the one we couldn't get a gross total resection. We did a gasket seal, and we had lumbar drain or an EVD. We had one CSF leak. We did have a lot of anterior and posterior pituitary insufficiency, 90 and 70%, which is similar to what you would expect. But we were able to get these tumors out, and the patients actually did quite well. So intraventricular in the third ventricle is not a contraindication. You just have to know you're probably going to become hypopituitary afterwards. So conclusions: endonasal surgery achieves equally higher rates of gross total resection with better visual outcome, more CSF leaks, although with hydrocet, I think we can get that down to 0. Trade seizures and wound infection for sinusitis and anosmia. We have our own set of complications with the endonasal approach. But craniotomy has its own set of complications as well, and those probably balance each other out. So you have to counsel your patients well about that. Gross total resection, in my opinion, in my hands, reduces the rate of recurrence compared with subtotal resection plus radiation. If the tumor is less than 10 cubic centimeters, chance of gross total resection very high. If you can save the stalk and achieve a gross total resection, that's ideal. But it's often better to sacrifice the stalk to get a gross total resection, unless you have hypothalamic involvement in a pediatric patient, and then you do have to leave tumor behind so you don't get obesity and cognitive changes. But even if you do a subtotal resection to save the stalk and to try to prevent hypopituitarism, you're going to end up getting hypopituitarism in about 2/3 of the patients. So you might as well cure them, in my opinion. Consider hydrocet, which will eliminate CSF leaks and your need for lumbar drainage. And if you want, I can show you a video of how I do that. I have it saved somewhere else. Thank you very much.
Thank you, Dr. Schwartz. Really spectacular talk and very impressive cases. I guess we can save questions for the end. I wanted to ask you, though, about your fluorescein protocol. When do you find that most beneficial? You only use it for cranios?
No, so I only use it if I am putting a lumbar drain in anyway, right? So it's basically cranios, supracellular meningiomas. Remember, I do all my tuberculum and plantar meningiomas through the nose. And then chordomas, right? If you know it's going to be an intradural chordoma. So it's not all the cases, just a limited number of cases. Now, I'm trying to stop doing lumbar drains, actually, in my supracellular cases because of the hydrocet closure. So I will probably do less and less fluorescein, but I do like to give it if you can, if you have access anyway, because it shows you where the leaks are. At the end of the operation, it'll show you that there's no leak at the end of your closure, which is useful. When you open up your arachnoid planes for the first time, you get this green rush of fluid. It's just very clear where the arachnoid is. So I enjoy operating with it. I think it is somewhat helpful, but I wouldn't put in, fecal access just to do that. It's only if I already have fecal access.
Sure, sure. And the other question I wanted to ask is, you have these challenging cases with tumor right up against the chiasm and sweeping the superior hypophyseal perforators, these very small vessels. Have you run into any issues? Can you advise on any technique that you can recommend for dealing
by the way,
with these small perforators?
I think I called them superficial hypophyseal. I was like stumbling over the word, but super hypophyseal. Thank you for reminding me. So, what I try to do when I open is open the arachnoid over the middle of the tumor, and often the vessels are sort of stuck to the back of the arachnoid where you just try to sweep. Now, they're also stuck to the tumor, right? And so, I have a 45-degree, almost a needle dissector that I'll try to use. I'll try to sharply dissect them off the tumor. And again, do my best to sweep them. At some point, some of them you often have to take out the tumor, but I just try to minimize that as much as I can. You just try to save them as the best you can, but you can take some of them. That's the truth. Some of them you can take and vision will still be preserved, but you just never know. And there's a great paper that was written showing about how there's redundancy in those superior hypophyseal arteries. And that does allow you to get away with some sacrifice, but you just don't know which ones you can and which ones you can't. So you have to try to preserve them all. Great.
Well, thank you again for that wonderful talk. So I'll introduce Dr. Sargi next, professor of ENT here in Miami. And on a personal note, I've had the great pleasure of getting to know and work with him this year, and just a phenomenal technical surgeon, and if it's even possible, an even better teacher. So Dr. Sargi, go ahead.
Thank you very much, David, for this nice presentation. I should be sharing my presentation. Do you see my proper presentation, or the presenter?
Yes, looks great.
Perfect. So thank you very much. It's a pleasure and an honor to be here. I was tasked by Dr. Morkos to talk to you about some skull-base reconstruction principles, pitfalls, and pearls, specifically for cellular and supracellular tumors, in less than 20 minutes. So I have nothing in terms of financial disclosures. I will be using some products using generic and brand names. I have no relationship with any of the manufacturers, and I do not necessarily favor one over the other. I wanted to throw this out there, and I want to thank Erin Riley, our fellow from last year, because I borrowed some slides and some videos from her presentation. Another disclosure slide for people who are interested in skull-base surgery. The North American Skull-Base Society is going back to in-person summer workshops in New Orleans this summer. This is an amazing course for people who are considering a career in skull-base surgery, ENTs or neurosurgeons. So I encourage all of you to attend, and save the date for February 2023 in Tampa, Florida, for the annual meeting of the North American Skull-Base Society meeting. So, I'm not going to repeat some of what was mentioned by my previous presenters, but planning the reconstruction starts from the beginning of the case. When you look at the disease, you anticipate what defect you're going to deal with, and this helps you start planning your reconstruction. It makes a difference whether you're dealing with a small cellular lesion with an expanded cella, or whether you're dealing with a cellular and a supracellular lesion. Of course, craniofrangioma or pituitary adenomas make a difference in terms of consequences of arachnoid defect and CSF leak. Either way, no matter what the reconstruction is, in Miami, it's common practice not to harvest a nasal septal flap unless we know for a fact we are going to need it. And most of the times we do not. And I will talk about our reconstruction algorithm. But what we do is we open the natural ostium of the sphenoid and we drop the mucosa on the face of the sphenoid. And you typically save the posterior septal branches of the sphenopalatine artery. For reference, this is a view of the left nasal cavity. This is the middle turbinate. That's the natural ostium of the sphenoid sinus. And if you save this mucosa between the natural ostium of the sphenoid sinus and the superior arch of the choana, you can take as much bone as you want to here, and we're able to go all the way down to the clivus without necessarily having to take the pedicle for the nasoceptal flap. So planning your cuts between the olfactory mucosa superiorly and what would become your nasal septal flap is extremely important. And then you can take the bone and the cartilage underneath it. So as part of the approach, starting to plan the reconstruction is extremely important. And then you are all familiar with this view, this extended sphenoid view of the sella with the tuberculum and the planum anteriorly, the projection of the optic nerves, the carotid, the paracellar and paraclival carotid arteries, and the optical carotid recess. So it's important for you to know if your defect is going to be sellar or sellar and supracellar, including the tuberculum and potentially the planum. And I'm not going to discuss the approaches, but those are relevant when you are talking about reconstruction, your defect. So what factors do you consider? Of course, the size of the defect. Is it a small defect or a large defect? And I don't think there's a clear cutoff between what is small and what is large. We know what happens on the extremes, but there are defects in between where we cannot really classify small versus large. Location, sella versus tuberculum versus planum. This has to do with the planar structure of the defect, the communication with the subarachnoid spaces, the proximity with important structures against which you may or may not be able to exert pressure. And I think this is extremely important. We classify CSF leaks in Miami as non versus low flow versus high flow. There are grading systems for intraoperative CSF leaks, grade 0, 1, 2, and 3. But there is a difference in our experience whether there is a CSF leak or whether there's no CSF leak, and we differentiate between low flow and high flow CSF leak. From my perspective, when there is a visible diaphragm or arachnoid defect, it is different from when you have CSF seeping through what otherwise seems to be an intact arachnoid. Do you have exposed neurovascular structures? Do you need to cover the carotid? Do you need to cover the optic nerve? Do you have a bone buttress against which you can exert pressure and anchor your graft or your reconstruction material without pushing directly on the optic nerve? Think about patient factors. Is the patient overweight? Is there an empty sella with possibility of intracranial hypertension? Does the patient have sleep apnea? Do they need to use a CPAP after surgery? Have they had surgery before? Is there availability of good quality nasal tissues, or are the nasal structures completely destroyed? And importantly, is there a need for radiation? Do you need to make that defect heal very quickly because you need to radiate the patient? Or can you just let them heal by secondary intention and manage them conservatively without the need for radiation? So what are the goals for reconstruction? You really want to decrease that space. The more that space you have there, the harder it becomes to maintain a graft, especially if you're using single layer closure. You need to create a watertight seal to prevent CSF leak, and by the same token, restore an effective barrier between the intracranial cavity and the nasal cavity for risk of meningitis. Risk of CSF leak post-op is much, much higher than risk of meningitis. Both are extremely small in experienced hands, but we worry more about the watertight seal. And you also want to cover and protect important neurovascular structures. It may be a good idea to put a graft over an exposed carotid in the sphenoid sinus or to cover an optic nerve. So some of the challenges that we encounter as we are doing the reconstruction, and the philosophy changes from one institution to another, from one team to another. In Miami, it's mostly ENT surgeons who perform the reconstruction. Neurosurgeons are done when the resection is done, and we take the patient back. In other institutions, neurosurgeons do the reconstruction. In many institutions, both surgeons work together. But some of the reconstruction challenges we have is lack of supporting structures when we have a very large defect with no buttresses that we can use. You want to think about the effect of gravity as the defect becomes more vertical if you have a sellar and clival defect. the pressure of the CSF, the movement of the soft tissues. You really want to maintain nasal function. Sometimes, maneuvering within a small space, potentially more with respect to the nasal space than the skull base opening when we talk about reconstruction. And also, there are challenging patients who are morbidly overweight, who have empty-sella in addition to their disease, who have sleep apnea, who need to use a CPAP. So what do you have available for you to use? Avascular tissue is something that's readily available, either autologous or allograft material. You really want a graft that could substitute or replace healthy, normal dura. You want a graft that's ideally well tolerated, and some grafts more than others could trigger some inflammatory reactions and cause granulation tissue and crusting. You want a graft that you can manipulate, that you can handle, that you can fold, that could respond to shaping and twisting, yet not be very hard, so it pushes on the optic nerve or on the carotid artery. There are also some dural substitutes, some absorbable hemostats, and some sealants that you could use, and I will let you know what we use in Miami. In terms of autologous grafts, you could use fat from anywhere in the body. You could use free mucosal grafts, typically from a piece of turbinate. If you choose to do a turbinoplasty, the nasal floor, we typically preserve the nasal septal mucosa in case we need to do a vascularized nasal septal flap. You could use fascia, you could use bone that you could harvest from the septum. If you're not taking your graft from the nose, you require a second incision, this comes with extra morbidity. The advantages is that those are cheap and those are from the patient, so they do not trigger immune responses and they're not likely to trigger inflammatory reactions. We have some dural substitutes, and you're all familiar with. Dr. Schwartz mentioned Alloderm as one graft that they have started using. Alloderm has been the workhorse graft for the past 20 years in Miami. That's what we have used. But if you don't have it available at your institution, you can find any other dural substitute that would work in a similar fashion, and you could use it for reconstruction. We also rely on absorbable hemostats and packing material. Those create some temporary pressure that allow the graft to sit and stick to the surrounding structures, but don't stay there, don't occupy the volume that they do in the sella on the long term. Those could be easily removed or suctioned in clinic. Some institutions use tissue sealants. We do not use tissue sealants in Miami. In my opinion, you achieve watertight closure with the first layer of closure, and anything you put on top of it is extra and could actually hide the CSF leak. So we have not used tissue sealants in Miami. And we've moved from being very aggressive, stripping all the mucosa and the sphenoid, to now preserving as much mucosa as possible. So I do not like to have a big glob of tissue sealant sitting on the sphenoid mucosa. We do not use non-absorbable hardware in Miami, but we oftentimes get patients who need revision surgery who have, porous polyethylene type meshes and non-absorbable grafts placed there. While those may be very effective in reconstructing the skull base, those become a nightmare when you're coming back for revision surgery, and they tend to get stuck and they're hard to manipulate. You can drill through them, but you cannot really control how you remove them. So we typically do not use those in Miami. In terms of nasal septal flap, you must be familiar with the nasal septal flap if you're doing endonasal surgery, because it really is the workhorse of reconstruction for vascularized tissue. This is basically an anterior-posterior sagittal cut at the level of the nasal septum with an outline of where the turbinates are. This is the sphenoid sinus, the olfactory mucosa, which is about 1 to 1.5 centimeter from the skull base. we start the incision in a horizontal fashion, and I usually follow the axis of the superior turbinate, and you extend the incision anteriorly depending on the length that you need and depending on the type of pneumatization of the sphenoid sinus. So the tip of your nasal septal flap could reach the edge of the defect. For a cellular defect and a supracellular defect in an average sphenoid sinus, a coronal cut between the head of the middle turbinate and the head of the inferior turbinate is typically more than enough. In terms of width of the flap, you can extend the flap all the way down to the nasal floor, or even include the nasal floor and make a cut in the inferior meatus. And then you would pencil down the mucosal cuts along the medial arch of the choana and below the natural ostium of the sphenoid. The cut along the choana depends on the arc of rotation that's needed to cover. If you have a larger and more anterior defect, you can include more of the anterior nasal septum. Even though the vascularization is not that reliable, you can basically get to the level of the columella when you're raising the nasal septal flap. And it's an axial flap based on the posterior septal branch of the sphenopalatine artery. So the advantages is that it's a large surface of healthy vascularized mucosa, and you immediately cover the entire exposed skull base, and this expedites healing. The problem is that there is some significant donor site morbidity. Patients complain about soreness and nasal pain, extended crusting, some problems with olfaction. I've had in my very large series of patients, one case of saddle nose deformity where basically the tip of the nose collapses because of lack of cartilaginous support. It's rare to see the nasal cartilage basically necrose when you raise one side of the mucosa, but it has been described. So we do not use the nasal septal flap for every single case because we think that the morbidity is quite significant, and we really need it. We really use it in cases where we absolutely need vascularized tissue. And I'll give some examples. So what do you do if you have a small defect with no CSF leak? Well, you honestly do not need to reconstruct this defect. You could cover with Surgicel, cover with gel foam. Sometimes, however, the area does not completely heal the way you expect it to heal. And while you see the entire defect mucosalize, you see a small divot through which you can look inside the cella, and this is an exam in the office, and the patients have an area of weakness where if they cough or if they push or if they do a Valsalva maneuver, they feel that their head is hurting them. You hardly ever have to go back and repair those, and over time the area becomes tougher and sturdier. But you need to know that if you do not reconstruct, sometimes healing takes a little bit longer and patients could end up with something like this. More significantly, if you choose not to reconstruct, if the patient develops a post-operative CSF leak, you have to take them back to the operating room. So you have to be careful when you decide not to repair. If you are in doubt, you should repair the cellular defect. So how about low flow leak? The University of Miami technique that was developed and pioneered by Dr. Cassiano, my former fellowship mentor and my senior partner here in Miami. It's an inlay-onlay graft of acellular dermis that is positioned in the cella for cellular defects and even intracranially for other types of defects. But this is essentially a depiction of the principle where the central part of the graft is placed as an inlay inside the defect, and the outer part is flattened around the edges of the skull base. The center is packed with typically gel foam and Surgicel that expand and create this cork-like packing inside the defect, and this allows the graft to heal without the need for any additional reconstruction. So a single reconstruction, a single layer alloderm would do it for most of our defects, including low flow and high flow leaks. Although in the high flow leaks, things have become a little bit more nuanced in my practice. So you need to have adequate hemostasis in the cella, and this is usually easily achieved with foam and Surgicel. After that, I take a piece of Alloderm that's about 1.5 times the size of the cellar defect. It has two sides. I like to place the rough side against the arachnoid because it sticks better. It's centered around the skull base defect, and we take tiny little rolls of gel foam wrapped in Surgicel, and those get pushed through the bony and dural defect, almost like you push a button through a buttonhole, and the gel foam expands inside the cella and makes the radial pressure such that the edges of the alloderm stick to the edges of the defect and create a watertight seal that we challenged with a sustained Valsalva maneuver up to 40 milligrams of up to 40 for about 5 to 7 seconds. And if the alloderm resists the Valsalva maneuver and we don't see a CSF leak, this is a watertight closure. Sometimes I advance the edges of the mucosa around the alloderm to expedite healing. And then we put small pieces of gel foam to protect the alloderm from getting stuck to the sponge that we leave in the nose. I used to put large pieces of gel foam, but you have to debride those and remove them in clinic. So it's much more comfortable for the patient to have just small pieces of gel foam. And then you advance a Merocell sponge that you allow to expand in this phenoid. And this holds the packing, this holds the graft in place. The packing is usually removed on post-operative day 2 before the patient leaves the hospital. So this is for low flow leaks. What do we do for high flow leaks? Well, there are multiple protocols and multiple reconstruction techniques that have been described by different institutions. Most of them require multi-layer closure. You've heard about the gasket seal technique from New York. You can read about the button repair technique from Jefferson, or the balloon stabilized graft from Pittsburgh. In Miami, we use the single layer alloderm. For high flow leaks that involve supracellular defects, we also use a nasal septal flap because those are the defects where we have the highest rate of postoperative CSF leak. The purely cellular defects, the rate of CSF leak is so low that the morbidity of nasal septal flap is not justified. This is an example of a cellular and supracellular tumor with a large defect, including arachnoid defect. As you see, we are looking basically in the ventricle with the choroid plexus. This case is being repaired with alloderm and nasal septal flap. Preparing the bed to receive the nasal septal flap, you have to strip the mucosa where the nasal septal flap is going to sit to allow it to stick to the skull base and avoid mucocele formation. The principle of using an alloderm is exactly the same. And as you can see, this is done by the ENT, mostly single-handedly. Sometimes the fellow or the resident or the neurosurgeon help with an extra hand, but most of the repair is done with a single-handed technique, the second hand holding the camera. Same principle. The alloderm is about 1.5 times the size of the estimated defect. You cannot push the alloderm too deep here because you have a large cavity, and the alloderm could basically go floating in the ventricle, and you cannot apply a lot of superior pressure because you may be exerting that pressure on the optic chiasm. You want to make sure the pressure is placed radially, so the alloderm is actually stuck around the edges and not so much pushed against the intracranial structures that you're trying to preserve. We're using a right-sided nasal septal flap on this patient, and you can see the nasal septal flap rotated from the nasopharynx where it was stored. You have to take the time to make sure it's completely unfolded, it's tension-free, and it's properly oriented. We work our way from the pedicle to the distal aspect of the flap. Sometimes we use neurosurgical pledgets or pieces of gel foam. And then you pack the nasal septal flap with gel foam so you can allow your marrow cell to go in and expand without it getting stuck to the nasal septal flap. So as you're pulling the packing out, you don't mobilize your entire skull base repair. And just like we did earlier, you see a marrow cell sponge expanded and pushed into the defect. This is looking from the opposite side. This is looking from the ipsilateral side where you see the donor site for the nasal septal flap. And this is how it looks like in clinic about 6 weeks when the nose is completely healed and crusting is gone. You can see the nasal septal flap going all the way. You can see the pulsations, and you can sometimes see the outline of the alloderm depending on the thickness of the nasal septal flap. You could also use fat when you have a larger defect without a bony buttress against which you can anchor your graft, and that's what a fat graft with a nasal septal flap looks like. And this is about 3 weeks from surgery. You can see some residual granulation tissue on the edges of the flap, but otherwise the flap is completely healed. There's a small crust here that I usually leave to fall on its own, and you can see transmission of the intracranial pressure, but you have a sturdy reconstruction and your patient is ready to start radiation fairly quickly. So in terms of post-operative care, we give them antibiotics to cover packing. We put them on CSF leak precautions, but I ambulate them on post-op day 1. We give them stool softeners. We make sure they don't lift anything heavy. We don't do strenuous physical therapy. We give them some sinus precautions, no nose blowing, no straining, no straw. We give them some saline rinses, and we tell them not to exercise or lift anything heavy, not to use a CPAP for a total of a month after surgery. Some of the complications related to reconstruction are CSF leak. Our experience is similar to what's been described in the literature. It's in the 3 to 5% margin, and some cases are slightly more challenging than others. Bleeding, especially when you're harvesting a nasal septal flap. Infection is extremely rare, and when we use fat graft, we typically use antibiotic irrigation. Scarring in the nose could be related to our reconstruction with synechia on the left side, nasal pain, crusting, and hyposmia related to harvesting of nasal septal flap. Pneumocephalus is less common, but is certainly a reason for you to have to go back and revise the reconstruction, even if the patient is not leaking. Vision change when your reconstruction is putting pressure on the optic nerve. So this is, CSF leak and bleeding are the ones that we see the most. So there are multiple algorithms in the literature, and I just picked a recent review article from the clinics of North America, giving an algorithm of reconstruction of cellar and supracellular defects, going basically from small defect, no CSF leak, to large defect with exposed structures and high flow CSF leaks. And you basically see a similar way of escalating the type of reconstruction. We do not use lumbar drain in Miami. We have not used it except for very rare cases. We do have excellent results, just like most centers. And if your results are excellent, you should not change them. It will take you a large series of patients to prove that your CSF leak rate of 2% is statistically significant compared to a CSF leak rate of 3%. So use whatever works the best in your hands, a plethora of allografts, autografts, and material. use the nasoceptal flap. When in doubt, reconstruct. If you don't know if there's a CSF leak, reconstruct. If it's a large defect, reconstruct. If the patient's going to use CPAP, reconstruct. The workhorse of reconstruction is really the nasoceptal flap. It comes with associated morbidity that you can spare for most patients. But if everything else fails, rely on a nasoceptal flap. And if your nasoceptal flap fails, there are some other vascularized options that have been described in the literature, like a floor of nose flap, like an inferior turbinate flap, even a middle and superior turbinate flap. You can also use pericranial flaps, and you could use temporoparietal flaps. In extreme cases, you could rely on a tracheostomy and a free flap if needed. Avoid overpacking. If you pack too hard, your reconstruction may cause more pressure on the neurovascular structures than the disease itself, and you may have to take a patient back because they develop blindness after surgery. Avoid using a lumbar drain. Consider using Diamox for patients if they are overweight, if you have a high flow leak and they have an empty cella. That may help decrease the incidence of post-operative CSF leak. Talk to your patients about post-operative nasal care with irrigations and debridement, avoiding crusting and colonized secretions in the nose helps healing and likely decreases the chance of an intracranial infection. Thank you very much, and I'm happy to answer any questions.
All right. Thank you very much, Dr. Sargi. Well, we are running a little bit short on time, but I want to get to a couple of cases, and I think Eva's got a good one to present. So Eva, if you're ready, you can go ahead and share your screen.
Okay, so this is a case of Dr. Morcos's, and so it's a 42-year-old man who was diagnosed with a supracellular lesion back in 2008. And so he had a ventricular peritoneal shunt placed, and also an intracystic catheter was placed at an outside institution. And then he was lost to follow-up for many, many years. And so then in 2021, he actually presented to our institution with left hemiparesis. And on exam, he had a partial third nerve, so his right pupil was 6 millimeters and non-reactive. The left was 2 millimeters. He had a right monocular temporal hemianopsia, and the left upper and left lower were 4- out of 5, but he was otherwise intact. And so here's his CT scan. You can see this calcified, multicystic supracellular lesion. And so I'll show the MRI in a second. Were you able to hear me, David? Oh, okay. So then, oh yeah, this is the MRI. And so you can see it's eccentric to the right. And so we wanted to ask our panelists, Dr. Schwartz, you kind of touched base on this earlier about the MRI findings, and you can kind of predict which kind of craniopharyngioma this is. And so based on what you were talking about earlier, what kind of craniopharyngioma would you think that this one would be?
Adamantinomatous.
Mm-hmm. And so our next question is, how you would manage this patient. And so, would you observe it or do, what things that you mentioned, like cisfenestration, fractionated stereotactic or hypofractionated radiation, intracystic bleomycin or interferon alpha, or would you do endoscopic intranasal? If you did microsurgery, what approach would you do? Would you use a lumbar drain? What side you would come from, and what degree of resection would you aim to achieve?
How old is the guy?
He's 42.
Yeah, so, obviously you can't get a gross total resection endonasally in a case like this, very unlikely because of the lateral extent. So that's not likely going to happen. The guy looks like he has hydro, in the short run, obviously you want to make his hydrocephalus better because he's not doing very well. So, you might want to fix his shunt just as a first operation and make sure that he's got some kind of, normal ICP. And so at that point, I think curing him is going to be challenging, right? This thing is wrapped around his PCA, his ICA. So I'm thinking in my head, I want to do an approach that's going to allow me to basically drain as many of the cysts as possible and then radiate him quickly afterwards to prevent it from regrowing and make sure his ICP is low. So I want to fix the shunt. I'm probably going to do a right-sided, terional. Maybe I'll take the orbital rim off to get a better exposure, split the fissure, and just try to get into all these cysts, decompress everything. But I don't think I'm going to peel the cyst walls off all the vessels. I'm probably going to damage something. So I'm just going to try to get in every single cyst, take the solid stuff out, decompress it all, and then send him for fractionated radiation. So I do an orbital frontal with a supraorbital osteotomy, just open widely and get it down.
So what we ended up doing was we did a lumbar drain. We came from the right side. We actually did a posterior petrosal retrolab combined subtemporal approach. And so, we drained about 30 cc's from the lumbar drain, did the mastoidectomy, and drilled down to the presigmoid bone, down to the presigmoid dura, and then skeletonized the sigmoid sinus, and then lifted an occipital temporal bone flap. And then after that, we exposed the middle fossa floor extradurally, then opened the presigmoid dura and also over the temporal lobe, and then joined those two cuts at the superior petrosal sinus, and then cut the tentorium all the way to the tentorial incisura. And so after that, we were able to see medial to cranial nerve 4 was the craniofrangioma cyst. And so then we started working extracapsular and tried to lift the cyst off the temporal lobe. And then, as we were going around posteriorly, as we were trying to lift the capsule off the SCA, the SSEPs dropped a little bit. And so we just decided to leave the capsule, because there were a bunch of perforators there. And so we ended up getting, here's the post-op scan.
Right. So you got to send him for radiation therapy. What was going on with his fourth nerve and his third nerve? Were they working perfectly?
So post-op, he still had his, initially pre-op, he had a partial third. And so post-op, he had a complete third. And then he also had DI post-operatively.
Right.
Yeah.
So, I've seen, Al-Mefti writes about that, getting into this, taking out these big craniofrangiomas through a transpetrosal approach. I never really got it. It never really made sense to me. Obviously, the results can be very good in the right surgeon's hands, so I'm not trying to minimize it at all. But it just never made sense to me to come this way as opposed to coming this way to take them out. I don't know what your thoughts on whether you considered, since you're probably not going to get a gross total resection. You're just going to fenestrate everything in this kind of a case. Maybe could have preserved the third nerve and the fourth. You don't have to cut the tentorium necessarily, but what are your thoughts?
I think the reason why we decided to, do the combined approach was just that there was a lot of the tumor that was in the posterior fossa as well. And so he wanted to try to be able to, lift some of that up. So we ended up lifting up the posterior fossa cyst into the middle fossa to try to.
I can see how it getting like, very high up posteriorly. That's why I would take that over. Although the frontal sinus looks very aerated, so that may limit the amount of that I could get. But I think either way, you're going to probably end up with a subtotal resection and radiation in this kind of a case. So
yeah, and if I could say anything in Dr. Morkos's absence, I guess I would say that it's what Eva's alluding to, which is that component that's just below the petrous bone, and probably what Dr. Morkos would think is the most challenging aspect of the tumor, and probably what he was targeting with the petrosal approach.
Right. Yeah, I would say that, what is the patient symptomatic from? What are we gonna? Even though it's hard to get that part out, and I agree with that. The question is whether you need to get that out if you're not going to get a gross total resection anyway. But
absolutely.
Either way, obviously, whatever in your hands you're most comfortable with being able to fenestrate the majority of the cysts is the right approach.
Mhm. Yeah. So I guess that's all we had. David, if you want to present your case.
Yeah, we're running a little short on time, but I'll show one more to get Dr. Schwartz's take on it. Dr. Sargi, this is a patient of yours and Dr. Morkos's, so you'll be able to share your thoughts from a treating physician's perspective. Let me pull up the case. And it's rare pathology. I'll share the pathology is juvenile ossifying fibroma of the skull base. And this is a patient that we treated recently, a 20-year-old who had a very large tumor, presented 2 years ago with left-sided visual loss. And I'll show her scans now. And while we watch the videos, Dr. Schwartz, have you seen this pathology in this skull base? I'm sure you have with the thousands of patients you've treated. Do you have any experience with juvenile ossifying fibroma?
Yeah. You know, we've probably done one or two. I can't remember a ton of them, but yes, I'm just sort of looking at your imaging to figure out. Yeah.
So I think the natural response that Dr. Sargi, Dr. Morkos, Dr. Schwartz, you would give at that point is to take this patient for an endonasal resection, which is what was done. And Dr. Sargi, Dr. Morkos accomplished a 98% resection. And do you have any thoughts on the case at this point, Dr. Sargi? Do you remember her?
Well, what was left behind? I guess that's what I would ask you. Where?
This is the post-op, and you can see some right along the tuberculum and laterally as well. And I'll replay this post-op film. This is her immediate post-op MRI.
Her sense of smell was gone, pre, post?
Gone. Mm-hmm.
Gone pre or gone post?
Gone post. And here's the residual.
Yeah.
The initial tumor was surrounding the carotid artery, and then I'll show.
Were you able to decompress the optic nerves bilaterally all the way back?
I do believe.
Yes, we were. Yes, we were. But this was not a very satisfying resection because we couldn't see clearly the edge of the tumor from the normal surrounding bone. And I think there were some areas where we were not sure we had tumor, if I remember the case correctly. So this was an unusual case. I've done ossifying fibromas, but I've not done ossifying fibromas that are this large. And this was an unusually bloody one. But, you know, I think we achieved what we intended to achieve.
And if anybody's interested in this case, this has been published by Nick Kahn, Dr. Morkos's former fellow and current faculty at Semis Murphy in Tennessee. And here's the publication for that initial operation.
So how is the vision after surgery?
Her vision improved. Her vision improved from 2300 to 2100. But unfortunately, her story doesn't end there. It's recurrent pathology. And I'll show you what her scan looked like just recently when we saw her after complaining of 4 months of visual deterioration again. And now her left acuity is 2400. And so the question now, I guess, is how do you approach this recurrence? And you can see on these films the recurrence surrounding both optic nerves, well, surrounding the left optic nerve and definitely involving the right side as well, and then surrounding the carotid arteries.
Yeah, it looks like the clinoids are enlarged and probably need to be resected here.
Yeah, they're essentially replaced by tumor.
Yeah.
So is there an endonasal option for this pathology?
You know, I'll be honest with you, when I've tried an endonasal approach and I've not been able to get out the whole tumor and the tumor recurs, in my mind, it makes no sense to say, all right, I'm going to go back and do a better job the second time because you've done the best job you could and you were not able to get it all out. So I would not go back endonasally. I like to go through a new route. I don't like to go through a reoperation. And look, you did the best job you could the first time and you were not successful at getting everything out. And so there's no, you know, there's that old expression like, you know, insanity is doing the same thing twice, thinking that you're going to get a different outcome the second time. So I would definitely not go endonasally. I would do, you know, probably a bifrontal craniotomy to come. You want to get it both sides, so you have to do some extended bifrontal supraorbital osteotomies or take the orbital rim, whatever you want to do. Some extended approach.
And what Dr. Morkos ultimately decided on was a left side approach, just given that her vision was bad on that side and trying to help that optic nerve. So this is a left cranial orbital approach, and you can see that the clinoid is completely replaced by tumor and the optic nerve is surrounded by tumor. And it's this soft kind
I
of
love that drill. What kind of drill is
bloody
that?
bone. Say again, Dr. Schwartz?
I love that drill. What kind of drill is that?
This is a Medtronic Clearview drill with a guarded drill tip, protected shaft, and it's a self-irrigating drill.
Beautiful.
Yeah, it's definitely a favorite of Dr. Morkos. The tip is curved so you can see it really nicely.
There's a lot of good stuff about that drill.
So this is a medial aspect of the optic nerve. And this is the space where the clinoid was. And Dr. Morkos was pretty careful around this clinoid because the carotid artery was encased by the tumor, as you could see pre-op. I'll skip ahead here. But eventually, what he was able to achieve, this is now looking across after a little while of drilling the medial tumor. This is looking across to the contralateral posterior orbit, periorbita. Found the carotid artery on the contralateral side and skeletonized, decompressed the optic canal on the right side as well from this left-sided approach. What was the challenging part, which you alluded to on your comment about a bifrontal, was the superior most aspect of the involved clinoid on the contralateral side, and ultimately not safely accessible via this route. But you can see Dr. Morkos pulling down the shell of the tumor on the contralateral side. And at the end of the operation, got a very good resection, probably not 100%, and a good decompression of both optic nerves, and ended up repairing the skull base, staring into the posterior ethmoids and sphenoid sinus, repairing the skull base with an abdominal fat graft. And she's done well. Her vision is stable post-operatively. So hopefully she recovers and improves here.
It's a great job.
All right. So with that, if there's no other questions from the audience, let's see if there's any open questions. I don't see any. Thoughts about a mini-terional transtentorial approach, transcavernous approach for something like Dr. Morkos's cystic craniopharyngioma.
Mini-terional.
Transtentorial, transcavernous.
Yeah, I mean, I think when you have a giant tumor like that, yeah, look, if you're going to do a subtotal resection, then that's possible. Mini-terional with a transtentorial, I've never done that, so I'd have to kind of think about it.
Yeah.
You know, I've only taken the tentorium through a transpetrosal, which is what you guys did. So don't have a lot of experience with it, to be honest with you. But I feel like, look, there was this huge cystic component that I think would create this enormous corridor for you. And so I think if you just came in anything from the front and kind of just followed the cysts, they would take you everywhere that you need to go.
Yeah,
that was my sense of why I didn't think I needed to do a transpetrosal for that, because, you know, there was just this enormous corridor from the cysts themselves once you got into one.
Well, great. Well, thank you to Dr. Schwartz, Dr. Sargi, and Dr. Cavallo in absentia, but it was a great discussion. Great to have you, Dr. Schwartz. Thank you very much, Dr. Sargi.
Yeah.
And
Great
thanks,
job,
Eva.
Dave.
And to everyone else, thanks to the audience for your participation, and look forward to seeing you at the next symposium.
Thanks. Take care.
Thank you.
Bye-bye. Good night, everyone.